order to be sure that our sample is non-clinical, all participants who had PTSD were excluded from our group. So we only participants without PTSD took part in our study. Then we used linguistic inquiry and word count, which was reproduced by Tashik and Pennebaker. And it is a software tool which could analyze text and define linguistic categories like pronouns. So we try to find agents, internal, external, verbs which denote predicates, and categories of time and place as a component of propositional structure. And this software tool, Luke, also defines the psychological meaningful categories, and we try to define negative emotions and anxiety. And our findings are the following: that according to the first research question, we found that results that participants have higher frequency of categories they, like external agent, in psychological categories of negative emotions and anxiety in traumatic narratives compared with positive narratives. The results also indicate that the higher number in traumatic narratives indicates that there is higher number higher word number in traumatic narratives compared with autobiographical narratives. Probably it is surprising, but we have to take into consideration that our sample was non-clinical, and it means that these people experienced traumatic event, but they coped with this traumatic event successfully. So we could assume that when person is concentrated on external agent, not on self, because concentrating, focusing on self is often associated with a complex of guilt. So when person is focusing on external agent instead of internal agent, when person focuses on negative emotions, anxiety, and could express it in long narratives, so don't try to avoid producing this narrative. Good predictor, robust predictor for coping with traumatic event and preventing transforming it into PTSD. The next finding connected with research question 2, that the external agent they and categories of time and place taken together significantly contribute to word number in traumatic narrative. We used here regressive analysis, and only the category of time is a significant negative independent predictor of word number. So it means the less frequency of category of time, the larger, the longer is the narrative. It is connected with previous research, as time is often overestimated when person has PTSD. So again, if person is coping successfully with traumatic event, probably this person is not focusing a lot on concept of time, but instead it could concentrate on place or external agents or something like that. And the last finding, that we found the positive correlation between social category like family, neighbors, colleagues, and word number in traumatic narrative. And it is in line with other research that people cope with a traumatic event successfully when they have very good social support. And the limitation of the study that we use not only non-clinical sample. It would be very interesting to compare traumatic narratives of people with PTSD and without PTSD. And another limitation is that it is important to admit that verbal expression are not completely isomorphic to memory representation. So we cannot identify language and memory. But we follow the idea of Bauer that life story or life narrative shows not autobiographical memory per se or traumatic memory per se, but rather its dynamics. And for us, it's very important, because for us, it's very important to find dynamics of some representations. For example, if to say for practical application for treatment PTSD, or just for preventing transformation of a traumatic event into post-traumatic post-traumatic stress disorder. The main conclusion of our research is that autobiographical and traumatic memory might be examined through psycholinguistic markers represented by propositional structures and psychological meaningful categories in individual narratives. And the main practical issue we could use it when we are working with PTSD or with preventing PTSD after some traumatic event, because propositional structure could define some hot spots in traumatic personal experience. Thank you for attention, and now I try to come back. I try to come back. Do you hear me? Yeah, okay. Did I stop my slides, my presentation, yeah?
Yeah.
Okay, thank you. I'm ready for your questions.
Can I ask, Larysa?
Yes, welcome.
Yeah, Larysa, how do you think, what is the good predictor of emotional condition in auto-narrative or narrative?
A good prediction of what?
Of emotional condition, people, actual emotional condition.
In autobiographical?
Yeah. We can, if you read the narrative on other people, we can predict the emotional condition of these people or not?
Based on their speech?
Yeah.
Yeah, we just, it's a very good question, because we just compare positive narratives with negatives in different, just our task was to compare positive autobiographical narratives with traumatic narratives, but we didn't perform some regressional analysis inside of autobiographical narratives. It is a good prospect to do it earlier, yes, because if, for example, we take all these variables and make regression analysis inside of positive events, we could define what predictors are in these autobiographical memories. But for us, it was very important to the goal, the aim of this research was to focus on traumatic narrative and try to find some signals for traumatic memory, which is different from PTSD. And autobiographical narrative we just used in order to compare it with traumatic narrative, just to show that they are different, quite different. But it's a good prospect for further research, yes, to study autobiographical narratives and with negative events as well. But here is very a huge problem to differentiate where is negative life event and where is traumatic stressful event.
Thank you.
Thank you, Larysa. That was very interesting. A quick question. Were the narratives collected orally, or did the participants...
No, in written form. In written form, yes. Okay. They have some time, and they came to the laboratory, and they just... we used SONA system. It means that they have some points for their credits, extra points. And students who agreed to participate, they came to us and write. They have 30 minutes. And they write their narratives. One group was writing negative, traumatic experience, and another one positive. And it was very important for us that all of them have no PTSD, because a large number of students had PTSD because it was connected with some events in Oklahoma. There were some acts of terrorism just not far away from this period. They have natural disaster with tornado. So we had more than 11% even of this PTSD. or some tendencies to PTSD, so we exclude these students from our sample.
Mm-hmm. And was there a specific, were they just given broadly, write about a positive event in your life, and the other group write about a negative or traumatic? Was it just presented very open-endedly like that? So they were deciding what was a traumatic event?
No. We divided, and it was a clear instruction. We decided who has to write about positive and who has to write about traumatic experience. Yes, the most traumatic experience of their life. Mm-hmm. And of course, they were very different, because for one person it could be like a dog or pet. Mm-hmm. But for another person, it could be sudden death of significant relative or friend. Yeah.
Great, thanks.
Mm-hmm. But it's very important that this person consider this event as traumatic. Yes, it's. Mm-hmm. Yeah, thank you. So we could continue, right? I have to continue. I'm the leader, right? You just monitor time.
Yeah, yes? That's right.
Okay, yeah. Thank you. Okay, so the next is Azizuddin KHAN. Is he present? No. So Maryna, ORAP, Involuntary Narratives in Traumatic Memory Reorganization with Healthcare Framework.
Hello to everyone. Can you hear me and see me?
Yes, everything is okay.
Mm-hmm.
I don't see myself. I want to present a study, Involuntary Narratives in Traumatic Memory within Healthcare Framework. I want to open my presentation.
Mm-hmm.
Guys, just in case any of you can't present, in another room there was a problem that one of the presenters couldn't present their screen, so you could send your presentation to somebody's email, and we can show your screen for you, just in case there is any problem, okay?
Okay. Larysa Vladimirovna, can you show presentation?
Yeah. Okay, I try.
You have to, if you have the presentation, you can share her screen, huh?
Mm-hmm. Just a moment. Mm-hmm. Just a moment, I found your presentation. Savchenko, Maryna. Mm-hmm. Not so easy.
I see.
Yeah. Could you?
Larysa Vladimirovna, I find how. Yes.
Perfect.
Can you see? No?
You have to click on present a window. Present now a window.
No, Larysa Vladimirovna, не виходить.
Не виходить зараз.
I see.
Just we'll try to do. We have a lot of time. Don't worry, because not all presenters are present. Mm-hmm. Mm-hmm. Could you see?
Oh, okay. Yeah, it's restarting. Okay. Mm-hmm.
No, just.
You could just enlarge the screen a little bit, please.
I cannot see. Oh, it is the first. Yeah. Maryna, could you see?
Oh.
You cannot see presentation?
No, only Martha's picture.
Лариса Володимирівна, я замість вас бачу презентацію.
So could you talk? Is everybody does everybody see this presentation or not?
Before, yes, but not now.
Ah, not now.
When you were presenting, Larysa, we could see. Now that Martha is presenting, we can't see anymore.
Why not? I do not know. No.
Давайте ще раз, Лариса Володимирівна. Давайте, може, це я щось зрушила?
I'm
Could you
sorry.
see now? No?
Yes, now okay. Yes.
I can talk right now.
Yes.
You could see, yes? You can see. Sorry,
Okay.
can you see?
Yes, we see.
Nice.
Just a little too small. If you
Uh,
could go to the
It's
inferior
small.
right and expand a little bit the percentage of the screen.
Лариса Володимирівна, поміняйте на показ слайдів, не заметок, а показ
Окей.
слайдів. You show, ви показуєте замітки.
Just the slide.
Там, де від,
А в мене ж немає нічого.
вверху
Це
на
те, що ви
червоному,
мені- А,
від, от там, де
окей.
написано від.
Ну,
And the
От, і
slide.
там є обичний
І що?
зліва, самий крайній зліва. Обичний.
Є.
Ні, не масштаб, оце о.
Нормально.
О,
Yep.
yes.
добре? Мгм.
Окей. Now, самий верх. We present study involuntary
good
narratives and traumatic. Yes, traumatic memory reorganization within healthcare framework. This study was aimed by practical purpose because oncological diseases today, despite new approaches, remain a complex medical, next please, medical, psychological and psychosocial problem. And this problem is especially acute in Ukraine, where a higher level of cancer is registered in comparison with the average world standards. For example, more than 300,000 again, 340 against 229 per 100,000 of cancer patients. Ukraine ranks second in Europe in the rate of cancer, with about 160,000 Ukrainians finding out to have cancer each year. So you can see these scores about Ukrainians who was diagnosed with breast cancer. Next. And cancer belongs to the category of diseases with high stress potential and due to significant changes in physical health, negative prognosis for life, and complex treatment. And the worst in this, according to Ukrainian scientist Mukharovska, is that more than 62% of cancer patients in Ukraine have maladaptive types of response to the disease, which significantly complicates both the patient's conditions and cooperation with doctors. Thus, depression and anxiety are the most common psycho-emotional complications among cancer patients that PTSD. Next. So we focused on studying traumatic event in the history of oncological treatment. A special case of situations in cancer treatment is the situation of announcing the diagnosis and the subsequent choice of treatment strategy. Researchers are studying this from the standpoint of traumatic situation, which often activates the person's deep social archetypical attitudes about the inevitability of death due to this disease. The shock of reporting the diagnosis is largely due to the disease's social stigma common in Ukrainian society, stereotypical associations of cancer with shame, guilt, and death. And that's why the insomnia disorders, pessimistic views, and consequences of the diseases, the inevitability of death are added to the clinical structure of the anxiety reaction, according to our study. The presence of increased anxiety, which can develop into depression, negatively affects the course of cancer treatment, of course, and attitude to the doctor and treatment procedures as a whole. Please, next. And narratives widely used narrative methods, especially in such traumatic situation, as Penny Baker and Siegel described in detail and summarized all the known effects of using narratives. So it was found that writing or talking about traumatic experiences can reduce stress, increase positive emotions, and cope with traumatic situations. Numerous studies in the scientific literature hold that expressive writing is a useful tool to take care of the person as a whole. In particular, expressive writing and positive writing are actively used in the therapeutic work with cancer patients. And next, that's why, however, despite the undeniable positive effects of narrative methods, we find the opposite opinion in modern researchers. As Penny Baker points out, there is some evidence that writing may not always work by itself in samples that may have disordered cognitive processing or relatively severe depression. We found studies that dispute about the benefits of expressive writing are undeniable. For example, Marlowe in 1999 reported that writing about negative and positive life events produced no physical health benefits in undergraduate students. A study by Sbarra in 2013 demonstrated that traditional expressive writing can worsen a person's emotional state in emotionally negative situations. The authors associated this with the need to reflect on their emotions, which does not improve the overall emotional state. For example, Gidron, Perry, Connolly, and Shalev in 1996 suggest that writing may not benefit PTSD patients in the absence of cognitive and/or coping skills training. Further, several cases of PTSD may be associated with the inability to organize cognitively traumatic experience despite the continuous ruminating and emotional responses to thoughts of the precipitating traumas. In the review article, Mertz, Fox, and Malcolm in 2014, 13 articles about experimental trials and of cancer patients who participate in expressive writing were analyzed, and all they came to the conclusion that although the majority of the intervention effects were null, there were several main effects for expressive writing on sleep, pain, and general physical and psychological symptoms. And that's why, thus, while affirming positive effects of expressive writing techniques in the processes of long-term therapy associated with self-awareness, we find alternative studies which indicate that there are certain psychological situations in which the need to create a story provoke anxiety or tension. And that's why, in addition, next, please. In addition, our own experience of working with cancer patients in remission has shown a significant impact of the traumatic event on people's current life. There are many narrative methods that we successfully use to reorganize traumatic memory, and the use of these methods in patients in remission has shown a significant emotional response to traumatic events of past experience. Using traditional narrative techniques, including autobiography, Says My Life and My Perfect Day, in correctional work with cancer patients in remission from 1 to 10 years after recovery, we saw certain features. These narratives contained markers identified by Larysa ZASIEKINA in 2015 and 2017 as indicators of the presence of traumatic experiences, such as an increase in the average sentence size, an increase in the number of sentences, a decrease of future events, and an increase in negative emotional events. These prompt us to look for other ways to reduce the traumatic experience. Please, next. Based on what tools can help? Based on theoretical analysis and practical observation, we suggested that the necessity to control the correctness of the opinions formation in the creation of narratives prevents the free residence of emotions. This led us to think about the need for emotional, not limited to a certain framework, free and spontaneous response to the problem, and to find non-traditional forms of narrative techniques. In the scientific literature, speech and narrative as a product of speech is studied mostly as a conscious, structured, prepared, and controlled process. But what about uncontrolled speech? The idea of uncontrolled speech first was introduced in The Artist's Way by Julia Cameron, you see, in 1992. And reflecting on the ways to obtain, renew the creative impulse, the author notes the bedrock tool for creative recovery is something I call morning pages. 3 pages of longhand morning writing about absolutely nothing. Julia Cameron compares such writing to meditation, which frees her consciousness from superfluous thoughts, structures the experience, and release creative energy. Similar idea we can see was expressed by Julia Lamotte in her book Birth to Birth, Some Instruction on Writing and Life. And very interesting, this idea of involuntary speech in another definition is used in Brené Brown's Rising Strong. As Brown notes, the most effective way to awaken understanding is to record your stories. And explaining the benefits of self-understanding, the author emphasizes that people often encounter internal resistance to such writing precisely because of the need to structure the story and comply with certain rules and standards. Therefore, Brown proposes to create a so-called shifty first draft, in which you can afford to describe your emotions in any sequence, in any words, turning off internal censor. So this, please next. This gave us the idea that writing involuntary, uncontrolled, unprepared, and non-structural notes may help reduce negative emotions about traumatic event and reorganize in this way traumatic memory among patients with cancer diagnosis. The main idea is simple. Immediately after awakening, write down all the thoughts in the form in which they come to mind. Without proper grammar design, not observing spelling or syntax rules, a technique called Aber's mental shower. Theoretical study of different types of awareness level, arbitrariness, and preparedness of speech has led to the need to generalize the speech definition, which is characterized by unpreparedness, spontaneity, and low level of awareness. We choose the term involuntary narrative as opposed to voluntary narrative, which is conscious, controlled process. We are fully aware that we cannot even rightly use the word narrative next to the word involuntary, because the narrative presupposes obligatory awareness and goal setting. But therefore, we emphasize that we use this term conditionally in working order without claiming for its full theoretical justification. Please, next. And the main question of our study: does involuntary narratives help to reorganize the traumatic memory? Next. The study was conducted with the patients of Oncology Center in Ternopil, Ukraine. The sample consisted of 49 women who were diagnosed with breast cancer, mean age 55 years. Respondents were selected on the condition of voluntary consent to participate in a psychological research and correction program. They were informed about the features of this program, and therefore the sample consisted of patients with more than 1 year after treatment and who showed high-scored PTSD. Scientists, KHAN and others, claim that scores of more than 100 on the Mississippi scale indicate the presence of PTSD. Please, next. And the procedure had 3 stages. Stage 1 aimed at determining the current level of PTSD reaction in whole sample. We choose instrument, you can see Mississippi scale for combat-related post-traumatic stress disorder, and also we diagnostics narrative techniques, including psychology autobiography, for such indicators, as you can see at your slide. Okay, next. Stage 2, experimental stage. At this stage, the total sample was divided into 3 samples. Group 1 includes the respondents who volunteered to perform the mental shower techniques for 10 years, every day, every morning for 10 days. Participants got such instruction. You can read for yourself. I will not read for you. And these records, very important that these records have not been read, edited or commented on by author or anyone else. They were not stored, not discussed in groups or individually. Participants in group 1 was voluntary based on the expressed desire of the respondent. At the end of the experiment, participants were able to voluntarily express their impressions in the interview, impressions, thoughts, and the consequences of the corrective exercise. In group 2, there are respondents who did not want to participate in the experimental program to reduce anxiety. They did not take any special organized impacts to reduce anxiety or any another psychological work during these 10 days. And group 3 are respondents who voluntarily agreed to use traditional narrative methods. 2 consultations were held with this group in the same 10 days using narrative methods, my autobiography and my life. Please, next. And after 10 days, it was stage 2, consisted of calculating the level of PTSD and the level of, in all 3 groups. This gave us the opportunity to compare the indicators of anxiety, the indicators of PTSD, and that's why, and make a conclusion about recognize or not of traumatic memory. Please, next. We come at the table 2. You can see the compare comparison the respondents' PTSD scores in statement 1 and statement stage 2 in each of 3 groups. The result of statistical calculations show the decreasing of the mean scores of PTSD in the at the statement stage 2 in all groups, but statistically significant differences between the scores at the statement stage and statement 1 and statement stage 2 were found only in group 1. You can see T-score student, T-test student. You can see score 5.146. That is critical, and this means that the mental show method helps to reduce negative or traumatic memories in breast cancer patients. Next, please. And table 3 show us the changes in narrative indicators. So you can see the changes in narrative indicators that indicate the level of PTSD. From the table, we see the changes in all indicators show a decrease in the level of PTSD in experimental group. First of all, decreasing of sentence size, average number of words in a sentence, that indicates a decrease of emotional response. Second, decreasing the number of sentences indicates the structuring of the traumatic experience. Third, increasing in the number of described future events, which indicates an increase in optimism and life prospects as well. And four, reduction of the number of described past negative events, which indicates the interweaving of traumatic experience in the individual's life experience. Next, and the peculiarity of using the mental shower technique was that involuntary narratives were not subject to further editing, rereading, or discussion, and patients also did not read or store them. According to the respondents themselves, they were ashamed to reread what was written there, or nothing could be understood at all from what I wrote. After the experiment, 10 days of morning writing and statement stage 2, we conducted the interviews with the participants, in which more than 90% of the respondents expressed general satisfaction with the performed methods. Answers for the question, what did this technique provide you with? In more than 60% were emotional relief, improvement of emotional state. In 31%, feel free from stupid thoughts, put everything in places, that is about the cognitive way of processing one's own mental states. According to the patients, this technique is like a mental shower, washes away everything bad from the soul. These are the words of one of the participants, and it actually gave the name to the technique. Thus, involuntary narratives fulfilled the mission to reduce negative emotions of traumatic event in the past, and in this way to reorganize traumatic memory in breast cancer patients. Next, please. And conclusion. Thus, the technique mental showing also provides uncontrolled release of all thoughts that arise in the mind, serves at the same time as a means of rationalization these thoughts and helps to reorganize them. Secondly, as a means of releasing and leaving hidden emotions. According to one woman, this exercise relieves anxiety and allows you to structure thoughts. We believe that this is due to the effect of mental cleaning, when the mind is free from all unproductive thoughts. Thus, we can predict that involuntary stories and narratives will help reorganize traumatic memory in breast cancer patients. Thank you for your attention. Next.
Right.
Yes, thank you. we a bit out of our time schedule, right?
Yes,
Yeah.
sorry.
Okay, thank you. Thank you very much for your interesting presentation. Do you have any questions? I have, okay, Elena.
Okay, Maryna, thank you. It was very great study. And I have one question. I very attentively read about this exercise, a mental shower, but I don't understand the mechanism which provides such great change. How do you think which mechanism? It's maybe externalization or objectivation. What do you think?
I think that this is like psychoanalysis methods, and it leads in externalization, because we out of any frameworks, yes, and out of any rules, we can get our thoughts very free. And that's why we don't control them, and we can go out thoughts that we can consciousness even.
Thank you. Thank you.
Thank you. I had the same question as Elena has, because, for example, according to Pennebaker, it's very important just not to talk about, yes, it's very important not just to write about facts, but about emotional experience, just about feelings which accompany these facts, yes. But in this case, but your technique, this technique, mental shower, is very good because it is distant from re-traumatization. Because if we are writing about traumatic event, we always have risk, if, for example, there is PTSD, yes, to repeated traumatization. But this technique, I think the great advantages of this technique, we have no risk for traumatization at all, because we just write about all things we want.
Yes, I thought about this. Thank you. And I want to underline that this technique is about writing all thoughts in incorrect, in what they come to you. That's why we don't need to think about how to combine, how to
combine them in some
combine words, for example.
Yes. Beyond of syntaxes of all of that.
Syntaxes or structure of sentences, we don't think about it, and this that lead us to free thoughts, and that's why we think that it helped to reduce anxiety, for example, negative emotions, and as a result, to decrease PTSD as well.
Yeah, thank you. Do you have some more questions? No? Okay, thank you. We are moving further.
Excuse me, I would just like to comment that it was very significant to me because my cousin is now treating breast cancer. And then while we were presenting, I was all the time thinking about my cousin. And so, and how difficult this disease is to treat and so on.
Sorry for your cousin.
Thank you.
But this is bad illness, but not. But she can
recover. So it is not the end. It's like probably.
It is not just the end, and
yeah, hope so.
Yeah. Thank you, Maryna. And the next topic is THUY. Are you here, THUY?
Yes, thank you,
Yes. It's so nice to see you again.
It's me again. Me too.
Yeah, so emotional memory impact on visual impaired children, inclusive settings communication. Are you going, are there both of you or you only one? Are you going to present?
I see in the screen is so small, so I'm afraid I cannot see. The screen is so small. I to put my presentation.
Mhm.
Yes.
Could you demonstrate? Share your screen with us.
Larysa, do you see my PowerPoint?
Yes, but I suppose you should send me your PowerPoint. No, we cannot see. We cannot see. Yeah? Yeah. It's better now. Probably there is some hint.
Okay, I cannot see my. I don't know how to share.
Yes, you were doing in a good way, but there were some options. Try to find.
Yes, I see it already.
Yes, we can see it. Thank you.
Okay. Have you seen it?
Yes, but it is not the first slide, I suppose. It is not the first, or it is the first.
Okay, I will move it.
Yeah. Yeah.
It's okay now.
Yes, perfect. Thank you.
Okay, thank you. Hello, everyone. Nice to meet all of you. And almost time I use Zoom, and now I use the Google Meeting, so not fluently. Also, my presentation is about emotional memory impact on visually impaired children, inclusive communication. And we have 3 people in the group, but I will represent of the group to present the speech. Because my subject is about children with visual impairment, so I would like to introduce something about types of disability in our country. In our country, we have the disability law in 2010, and we divided the disability into six types: mobility disability, hearing and speaking disability, visual impairment, neurological and mental disability, intellectual disability, and other disability. And this is the number of children with disability in Vietnam according to the Unicef 2017. And as you see, children with disability in Vietnam take 2.79%. And in the in my research, I focus on children from age 5 to 12. And you can see here, it takes about 2.81% of children with disability in Vietnam. Yes.
THUY, I'm sorry, but you do not show your presentation. We have only the first slide. Is it okay?
Sorry.
Yeah.
Can you see it?
Yeah.
Can you see?
Yes.
Can you see my? Yes.
Yes.
Can you expand your screen, please? It's just so small.
Small. Yes, I think so. Because I see another is small too. So maybe I will read it.
You just have to click on presentation, present.
Or maybe Larysa, please send my presentation for people in PDF. It's okay. And when because I work for special education faculty of Hanoi National University, so I have chance to work with the teacher as well as the children with visual impairment, and I discover some statement of problem. As in the slide, in recent decades, inclusive education for children with disability model has been implemented in many countries around the world, including Vietnam. In Vietnam, inclusive education has been determined to be the main approach to ensure learning and development opportunities for all children with disability. Also consistent with the education condition in Vietnam currently, as well as the trend education for children with disability around the world. The concept of inclusive education is updated according to UNESCO document. Okay. Is bigger? Now slide is bigger or not?
It's not bigger, but it's okay with me.
You were there. You were almost there. You just have to click beside 58%. There is a shape of a cup. Just click on that cup, and it's going to expand. Beside the symbol, beside 58%, there is a kind of a cup. Just click on that cup, and it's going to be bigger.
Okay. Yeah. Is bigger?
No.
No?
No.
Oh, Larysa, can you help me to show it? I send you my PowerPoint already.
Okay.
Okay.
Yes. Send me, please.
So I have stopped PowerPoint and Larysa will show it. Right?
I try. Try to do it now. Okay, let's do it. Let's try again. Can you see? Can you see?
Okay.
Yeah, but it's still small.
Small, still small, right? Okay.
Very small.
Okay, I'll try to make it. Is it better now?
Yeah.
Is it better?
Yeah. Almost the same. There is in the bottom to the right, there is a percentage. Yeah, to the left now.
Is it better?
No, to the left. Go to the left. There is the first icon on the left. It's a kind of a cup. Click on that cup, please. To the left.
Right or on the left? On the right?
No, to the right. Go to the right. No, here
No.
next to the date. Next to the date here, there is a kind of a cup, and it's a presentation mode. Yeah, I can see your icon, your arrow. Just go to a little bit to the left, and there is a cup, a kind of a cup. Yeah, to the left, a little bit. No, not there, not there. Go to the no. Yeah, there. Yeah, right. Click on that. Click.
Yeah. Is it better?
Still not in presentation
It's
mode.
small.
It's too small. Yeah, it should be there.
It's small?
Yeah, it's still small.
Okay. What is the next step?
No problem. There is here to the top, there is a presentation. I think to the fourth or yeah, to the top, there is a presentation. And you can say presentation mode there to the top, but your computer is in Russian, I can't understand. But okay, but we can see, no problem.
I was going to say, up along the top, there's a slideshow.
Yes.
Yeah, click that. And then
we just to demonstrate slide, you mean? What? Do you mean this?
Slideshow, and then...
Is it better or not?
It didn't really...
No?
And then click on the very first, Начало. Next.
Начало, yeah. Yeah.
Usually it would just bring the slide up.
Yeah.
I think it's okay now.
Okay.
Yes.
Is it better?
Yes, it's better.
Okay, let's continue. What slide you need?
Thank you, Larysa.
You're welcome. So what slide we need now? Types of disability?
The third, the fourth, the fifth one. The fifth one.
Here?
Next. No, not yet.
Here?
The side is the same with my side when I start with.
Here?
No. Above.
Further?
Above. About the fifth from the beginning.
Fifth from the beginning?
Yes. Okay.
Yes. Okay.
Yes. Thank you. This is the number of children with disability in Vietnam, according to Unicef in 2017. Children from 2 to 17 years old take about 2.29%. And in this research, I focus on the children from 6 to 12. And you can see it takes about 2.89% of children with disability. And in the month, 0.15% children with disability. Yes, next please.
This one?
Next, please. Next, please. Next slide, Larysa.
Next?
Yes. Next. Next. I cannot see it's next.
Next?
Statement of the problem. In recent decades, inclusive education for children with disability model has been implemented in many countries around the world, including Vietnam. And in Vietnam, inclusive education has been determined to be the main approach to ensure learning and development opportunity for all children with disability. And it's the trend education for children with disability around the world. I have a definition of inclusive education for the research. The concept of inclusive education is updated according to UNESCO document. Inclusive education for children with disability can be defined as is an ongoing process to provide a quality education for everyone with respect, diversity, and differences in needs and abilities, characteristics and expectations of students and communities in learning and eliminating all forms of discrimination. In Vietnam, inclusive education is understood as education method in which children with disability and children without disability learn together in same school in the right place where children live. And I have definition: inclusive classroom include students with visual impairment. Classrooms that include children with visual impairment in the stream school, in which children with visual impairment and sighted children learn together. Students have appropriate and reasonable rate. They follow general curriculum, which is adjusted and ensure all the necessary conditions to meet the needs and reach the highest level of student abilities development. To clear the content, we have a definition of visual impairment. The term visual impairment can refer to any condition in which eyesight cannot be corrected to what is considered normal. The term visual impairment is used to refer to a loss of vision, what makes it difficult or impossible to complete daily tasks without specialized adaptation. And students with visual impairment are those who have the disability of vision. When having supporting facility, they still have difficulty in activities that need of using their eyes. And many research confirm that students with impairment can be developed as every child if they are cared and educated with right method and suitable for their ability. This definition includes children with low vision and blind children. There are some impact of visual disability. Due to visual difficulty, children with visual impairment usually have limitation on various aspects like physical, emotional, behavior, cognition, language development. For example, impact of visual disability to physical. Children motor skills are often slower than their peers because they lack of stimulation for motor performance and opportunity for imitation. The coordination of information from senses to the organs is limited. Sensing distance and moving is difficult. They have difficulty in recognizing the body with space, difficulty in motor coordination, for example, ears and eye, hand and eyes moving. And almost children with visual impairment, if they have negative experience, they will fear of movement. Impact of visual disability on cognitive development. Low and Faith have said blindness causes severe limitation to cognitive development of the child because number and scope of experience limited. Other senses don't process information as effectively as vision. Ability to walk and interact with the environment limited. Effect of visual disability on children's cognitive development. They have a slow attention, lack of completeness, and slow perceptual process have resulted in attention-related effect in terms of volume, intensity, speed, dispersion, and concentration. Blind people have the ability to remember what they hear, talk, and remember for a long time. Effect of visual disability on language development. Language development according to the rule, pronunciation, vocabulary, grammar, and language received by hearing. Less use of a combination of multi-linguistic means at the same time. Restriction on the use of language combination. For example, body language, facial expression, speech language. Children or people with visual disability have the word repetition due to they have a limited vocabulary. They have a question too much and not suitable. Irrelevant comment to the content of the conversation. Empty language. For example, they speak without understanding. To widening or narrowing the meaning of the word. Limited vocabulary. Ability to receive concept and meaning. With written language, children with low vision often need to use enlarged font size, good contrast, and blind children use braille to read and write or misspell. Effect of visual disability on social emotional development. They have children are often passive, have little communication with others, or they refuse to cooperate and often fall into fear, especially when there is some disturbance in life. Social skills develop slowly. Social communication, violation of person's space in communication. For example, when they have interaction with other people, they tend to sit next closer to the person who talk to because they want to hear the voice, so they break the space in communication. Talking too loud or too loud because they can see so they don't know if people can hear clearly or not. So maybe they talk too loud or too low, too small. No initiation, no no initiation in communication. Inappropriate communication. They have a typical behavior. For example, they have a head up, ear toward speaker, eye up, take turns in social interaction, and they tend to focus attention on one's own action. For example, repeating questions, making unusual demands, changing subject suddenly, not responding appropriately to behavior. They expect expression of emotion does not match the face. For example, when they tell us about the funny story, but the face not change the emotion. They may have inappropriate response from children with visual impairment, significantly reduce the interest in communication. Children with visual impairment have difficulty understanding the appropriate way to enter, initiate, maintain, and terminate communication. For example, they have difficulty when join the conversation. Children with visual impairment cannot keep up with their sighted peer in activities that require many skills. They do not point body and face towards the person who are communicating with, because there is a tendency to listen in conversation. And the reason for my study is inclusive classes. Children with visually impairment tend to be isolated in the learning environment because of the negative content of emotional memory. The poor communication of visually impairment children has caused anxiety disorder and reduced learning outcome, as well as the relationship between the children sighted. It reduced the relationship with between children with visual impairment and children with sighted. On primary grade, primary grade is turning point in the child's life. It is also an important place to develop, to have of social interaction, create the good conditions for their development. And many researchers show that learning and knowing how to use social interaction skills are determined very important needs when learning in inclusive education environment, especially for children with visual impairment. The aim of the research, the aim of research, yes, thank you. The aim of research is to present theoretical and empirical data provides the idea. The impact of emotion, behavior, language expressed in social interaction skills on the implementation of effective communication of students with visual impairments in primary inclusive classes environment. The finding contribute in several ways to our understanding of a basic for treatment for communication of children with visual impairment, including classroom. methodology of research. This research have interdisciplinary approach of science, of physiology, psychology, operation theory, individual socialization, and principle of behavior repetition. Scope of research: the survey to assess current situation, emotional memory of children would be implemented in 4 cities in Vietnam, included 32 teachers, 8 administrators, and 31 students with visual impairment in first inclusive grade classroom. And the experiment would be implemented at 2 inclusive elementary schools. The content of survey: we survey 2 content. The first one is awareness, attitude of teachers in inclusive education, about social interaction skills and education social interaction skills for children with visual impairment. And the second one is student social skills and the relationship between student with and without the relationship between student with and without visual impairment in classroom. The method of the survey: we have a group method of data collection, questionnaire, observation, sociometric, and interview. Research profile. In the slide, we have a criteria for evaluating result. We assess the level of awareness and attitude, as well as the action by score factor, standard deviation. 1 is weak, 2 medium, and 3 is good. The second criteria assessment of student relationship in the classroom by sociometric indicator. Sociometric indicator will have we show us relationship between children in the classroom. And after the study, we discover that limitation of children with visual impairment focus on the 7 content. The first, participating in the game and just suitable for self-esteem. The second is communication. The third, self-awareness. The fourth, problem solving, group interaction. The sixth, recognizing and expressing feeling. The seventh, recognizing and control behavior. And the eighth, recognizing the privacy. And the limitation of attitude for inclusive classroom include children with disability, children with visual impairment is respect, love, goodwill, openness. All of the content we use to experiment with the children. Parallel with the content, we use measure. And here, use the for measure to apply to the children in the inclusive classroom. The first one is organize diverse interactive activity. The second one method is creating interactive environment. The third method is interaction and modeling social interaction skill for the children. The fourth one is conscious and use the social diversity situation. The fifth one is organize diverse interactive activity for the children. And the sixth method is support activity for students. We use the support of sighted students for children with visual impairment in activity and in the context of social interaction activity in the classroom. After experiment, we get the result as the scheme in slide. We can see mean score of student playing skill at the time of evaluation, before and after experiment. They have changed. Too quick. And with mean score of play skill and periods of assessment, we can see the mean score developed. It means that play skill have been increased significantly when comparing the result evaluated before and after experiment. The progress of relationship between students have more. The children with visual impairment have confidence and appreciate more as both children with visual impairment and children with sighted. And after all, I can have inclusion that all children have the capacity to learn and improve. Thank you. Maybe not good because the slide is very difficult to follow. I have a print and see the print slide.
Thank you, THUY. We probably one question because we are out of time again. So, do you have some questions? THUY, I have one question about emotional memory, right? Right, because the results, the findings show that they have poor self-awareness and they cannot express their feelings and emotions, right?
Yes. Cannot, but it's difficult, and there are limitations in express emotional and behavior.
Okay, but it doesn't mean that they do not feel. They feel, but they cannot express, right?
Yes.
Yeah.
And maybe they feel wrong. They feel wrong.
Yeah, because I followed the measures you suggested, and I didn't catch some measure which directed on this development of expression of emotional feelings. Probably it's very important step. It's psycholinguistic approach, right? Verbal expression of this emotional, negative emotional experience, how to express it. Because they do not see, but they could talk, they can speak. And, right?
To train, to develop the emotional, the teacher and the friend in the classroom can help the children with visually impairment by do the model. For example, like teach them how to talk, how to behave in situation.
Modeling, yes, modeling.
Modeling, yes.
Yeah, I see. Okay, thank you very much.
Thank you.
And now,
Thank you very much.
thank you. And now, Marta BOJKO, examining traumatic memory in cultural context using illness narratives.
Great.
Yeah.
Okay, now I will need to share my screen, so
Hopefully you do it yourself.
yeah, I'll try. So I just hit the present now icon, right?
Yeah.
Do I need to, okay, present now, and then I'll be able to go into my PowerPoint?
Yeah.
A tab, right? Is it a tab or a window?
Window, I suppose. It's to me window.
Window, yeah, window.
Window.
A window. Okay. There.
Yeah. Nice.
Okay, so you can see?
Yes?
You can, okay, because I can't see any of you. Is that normal?
It's a prize from Google Meet.
Okay, so I
can choose
can
what to see, your presentation or us.
I see. Okay, well, I guess, well, I'd love to see you, but I guess I'll let you see the presentation.
Yes.
Okay. I wanted to just. Cool. All right. Can you hear me, or is that from mine?
Yeah. No, Martha, it's perfect. You just, if you could, the same thing, if you could just increase your screen, expand your screen, the same thing.
Okay, I had expanded it up to be a slide. So let me just. And which one do I hit? Slideshow?
That one, yeah. Click on that.
Okay. Did it work there? I hit it.
Yeah,
Is it
not
showing
yet.
up?
Yeah. Okay, no problem.
So it's doing the same thing? Okay, sorry.
Yeah.
Okay.
I think there above on the view, there is presentation mode there above to the top. You have view.
View.
Slideshow, maybe view. Click there.
View.
View.
Fit to window.
Presentation mode or full screen. Slide master. There is a full screen mode or something.
Yeah, it's called.
Okay, no problem.
Yeah, I don't understand. Okay. Is it still showing the same?
Maybe slideshow. Slideshow.
And then that's what I was doing before. I hit from the beginning. I hit from the beginning, and it shows up on my screen as completely in the screen.
Yeah. Yeah.
Is it not showing up?
It's showing small.
Small.
technology sometimes
I know.
doesn't help. Huh?
Okay. Can you see? But I'll just go through. If,
Okay,
if
no
there's
problem.
a problem, then I'll try to, yeah, because it's showing up normal on my screen. That's why I can't judge what it looks like on there. But so the title is Examining Traumatic Memory in Cultural Contexts Using Illness Narratives and Explanatory Models. And a precursor, I am not a linguist, I'm not a psychologist, I'm actually a medical anthropologist and a health anthropologist. So I work within different clinical settings, looking at the cultural context of health and behavior. So the aims of this presentation are to understand the role of illness narratives and explanatory models in patient and provider relationships. Briefly describe the current frameworks which are being used to elicit narratives and explanatory models of illness experience. Take a bit of time to just look at how traumatic memory may manifest itself within these narratives and explanatory models of illness. And the last is to discuss the importance of a patient's trauma history, their cultural context, and attempts to kind of get a holistic approach to understanding a patient's illness and treatment plan. So illness narratives, one of the most powerful forms for expressing suffering and experiences relating to pain is the narrative. And it could be written, as Maryna had shown in her study, but they could also be oral narratives. And the illness narratives, it's a story that the patient tells about their personal experience of being ill. And it was a concept which was popularized by Dr. Arthur Kleinman. It started back in like the late 70s, 1980s. He himself is a medical doctor, a psychiatrist, and he's also a PhD trained anthropologist. So he's done international work, but he's also worked with patients, as we know, like in the United States or in many countries, patients are coming in from different cultures and different socioeconomic classes. So he was seeing what was happening in the typical physician and patient environment, and came up with a system to try to really get at what the patient was coming in with. He found that illness is multivocal, and the illness experience has meaning, and oftentimes has multiple meanings, each of which is worth examining.
Marta, could I interrupt you? I'm sorry, but you don't show your presentation. We can see only the first slide.
Oh, you're kidding. Okay. All right. I don't know why that's happening because I'm moving it along. Yeah.
Thank you.
I'm
Yeah, it's
sorry.
okay.
Can you see it? Can you see
yes,
it now?
illness narratives now.
Okay, then I'll just keep it at just this way. Okay, let me see.
Thank you.
Okay, can you see the next slide?
Yes, yes, yes.
Perfect. Okay. So illness narratives and explanatory models are important components of the patient-clinician relationship. They provide patients with an outlet to make sense of their illness experience, as well as influence their experience with the healthcare service. And I think I had stated before that illness is multivocal. It's the patient's explanatory model of illness that gives voice to pain and suffering in a way that lies outside the domain of biomedical, just the narrow biomedical voice. It's not just a disease. It's not just you have cancer. It's so many other pieces around it. And I know this came up in one of the previous presentations where it's not just the patient. There's the family, there's the extended family, there's the community. So there's many, many aspects of illness. So like I said, it's not just the disease. So back in 1980, Kleinman proposed eliciting the patient's explanatory model through a set of these 8 recommended and targeted interview questions to take place during the clinical visit. I know it takes time, but sometimes the time really helps both the provider and the patient better understand. So the questions are focused on what caused my illness. Again, the doctor, you can get the narrow medical view, but when you talk to patients, they have their own ideas. And also sometimes within traditional medicine, there may be some cultural explanations to what caused the person's illness, which would be helpful for providers to know. Again, they go, why did I become sick at this particular time? How is this illness working inside my body? What will happen to me? And again, then there's also how should it be treated? What kind of treatment do you think you should receive? What are the most important results you hope to receive from treatment? And we understand that there's, outside of, again, the biomedical treatment plan, there are other complementary alternative types of healing and treatment. So to fully appreciate the sick person's experience, the clinician must piece together this illness narrative as it emerges from the patient's answers and the family's complaints and explanatory models. They then interpret the narrative in light of the different modes of illness meanings, including symptom symbols, culturally salient illnesses, personal and social contexts. So these explanatory models are firsthand accounts of the symptoms and circumstances that the individual is going through. The proper communication within doctor-to-patient dialogue is essential to opening up full disclosure to what the patient has been going through. Proper communication between doctors and patients removes possible cultural and explanatory model barriers and results in a more specific treatment plan for the future. It's crucial to integrate the care of illness with the treatment of the disease. So again, we're talking illness and disease. In the 1990s, researchers and clinicians from McGill University in Canada expanded on Kleinman's patient interview questions. The McGill Illness Narrative Interview, called the MINI, but when you look at it, it's not really MINI, was initially developed to explore individuals' illness experience in a community study of help-seeking, medically unexplained symptoms and use of mental health services. The developers recognize that individuals use multiple representational schemas and modes of reasoning to produce illness narratives that are complex, sometimes internally inconsistent or contradictory, and that the narrative construction process has both internal psychological dynamics and external social dynamics. In looking at the psychological dynamics, includes the ways in which narratives are shaped by processes of memory and emotion regulation. And these narratives may undergo internal censorship, revision, and reorganization to maintain an account of self and others that serves the individual's goals and adaptation. So as we talked, narratives are multi-layered. We talked earlier, multivocal. Sometimes, words or phrases have multiple meanings. So, and with traces of their genesis in internal conflicts, biases, dissonance reduction, and efforts to attain a cognitive coherence as to the illness experience. So the MINI was designed to elicit 3 distinct types of reasoning about or representations of symptoms or illness. A basic temporal narrative of symptom and illness experience organized in terms of the contiguity of events. Also, salient prototypes related to current health problems based on previous experience of the interviewee the family members or friends in the social network, how the mass media plays into this, and other popular representations. And then also various explanatory models, including labels, causal attributions, expectations for treatment, course, and outcome. So what I was trying to do is place traumatic memory within this idea of illness narratives and explanatory models. So we had stated the psychological dynamics includes the ways in which narratives are shaped by processes of memory and emotion regulation. It's important to take into account the role of traumatic memory in the illness narrative and explanatory models. Traumatic memory is formed and stored very differently than everyday memory. People who have been traumatized or lived through adverse childhood or life events remember images, sights, sounds, and physical sensations without much context. It's considered, I guess, an implicit memory system. A particular traumatic incident may not be remembered as a story of something that's happened, or it happened a long time ago. Instead, it gets triggered by sensations that people are experiencing in the present that can activate their emotional states. So I think Larysa had stated early on, most people have experienced some sort of traumatic event, and the process afterwards of how, does it turn into, say, a PTSD, or is it coped? Have there been coping strategies? So people who experience traumatic events, and this could include natural disasters, terrorist attacks, war and displacement, accidents, assault, violence, rape, kidnapping, and also chronic exposure to psychological, physical, and sexual abuse. These types of traumas affect not only the brain, but also the individual's body and nervous system, which is a wealth of literature, which started, well, not started, but I think it was there before, Bessel van der Kolk's literature, The Body Keeps the Score, and how trauma is stored. Traumatic memories are oftentimes stored in the physical body. Previous traumatic experiences may also underlie many of the illnesses presented by patients. Research studies have documented an association between childhood trauma and adverse experiences and long-term health effects in adulthood, including cardiovascular disease, diabetes, obesity, pain, unexplained somatic symptoms, and stress-related illnesses. So this is the famous study back in the 90s about the adverse childhood experiences studies and the ACEs screening instrument to see before the age of 18 how many adverse experiences you may have encountered. Things like violence in the home, a premature death of a parent or loved one. So it's a way to kind of get a measurement as to the patient who's coming in. You can kind of, and it's a score from 1 to 10, and you're able to see each adverse experience, how it counts. And again, you're able to screen and identify whether a patient may have had exposure to childhood trauma or childhood adverse experiences. So the illness narrative and explanatory models, which occur in the clinical setting, present opportunities to identify and acknowledge a person's lived experiences and how those experiences may be impacting their current illness and treatment. So this may be a place to include an ACEs screen or other screening questions for the provider to get a more in-depth understanding of the patient. Together with the illness narratives and explanatory models is the importance of providers. And providers could be medical doctors, they could be social workers, they could be nurses, clinical psychologists, again, a broad term of providers. It's important for them to listen to and understand the words about the illness experience as well as the context of the experience. Kleinman talks about empathic witnessing is a moral act and not just a technical procedure. Part of what's been happening in the last few years is in this era of high-tech medicine, instantaneously available information, different foundations and researchers, so like the Robert Wood Johnson Foundation believes that stronger use of narrative has the potential to build bridges between patients and practitioners, data and knowledge, and the whole idea of hearing and understanding. So there's different sites, you'll see narratives that are written narratives. It's helpful for some individuals to write the narrative, but then, like I said, there's also interviews and oral interviews. And I wanted to kind of present the next. It's an example of a narrative that kind of encapsulates and kind of pulls together much of what we've been talking about in terms of typical provider-patient relationships and kind of what it should be. So here's an example of listening, hearing, and acknowledging trauma. And I'll read it to you because it's a very powerful narrative. It was, so this is a patient who has emphysema. So on her 4th visit to the emergency room, a patient with emphysema tells her team of providers that she hasn't been using the oxygen tank prescribed to her. The frustrated group of providers gathers to discuss the reasons for her non-compliance. And again, they start with the typical, she doesn't care, she's just too lazy to connect to the oxygen. I bet she forgets, she seems so absent-minded. And they all assume it's the patient's fault that she hasn't been using the oxygen. So within this group, what was helpful is, and oftentimes as an anthropologist, I kind of say this, it's like, why don't you just ask the patient? You know, it's her 4th time in the emergency room. You know, what's her, she understands the emphysema, she understands she needs oxygen, why isn't she using it? So she explains to them that her mother had been on oxygen when she was a child. Something went wrong one night and the oxygen caught fire, leading to the destruction of the family home. So it's this connection. Again, this may never have come out if they didn't come out and ask her, but she's already been 4 times in the emergency room. Something's not right. Why is this happening? And here out comes kind of a traumatic memory connected to the use of oxygen. So upon learning this, the team retrains the woman so she understands the safe use of oxygen, assures her it is safe, acknowledges the trauma that she felt as a child, and it becomes, after that 4th visit, there are no more emergency room visits for this patient. So to summarize, eliciting patient narratives gives the clinician knowledge about the patient, about the context of the patient. It allows for more shared decision-making. If the patient feels that the provider is listening and hearing what they're saying and trying to work together with them, that also makes for more effective treatment and healthcare management. Being aware of patients' life experiences and listening for cues of traumatic memory within the patient's explanatory model of illness provides an opportunity for providers to gain a more complete understanding of the patient's illness complaint and can play a vital role in supporting a holistic biopsychosocial approach to healthcare, which promotes the idea that disease is construed as the embodiment of the symbolic network linking body, self, and mind, and society. So thank you, and I'll get back to.
Thank you, Marta.
Hoping I'm there. Hold on. Let me stop presenting.
Thank you. Thank you for so interesting presentation. Do you have any questions to Marta? I have one question, I suppose, while the rest people are thinking, yes, about the questions. I wonder if it is different, so if it is important, this traumatic event in childhood, yes, turned into PTSD, or it doesn't matter. If, for example, it is just traumatic event which didn't turn into PTSD, could it do some effects? Could it impact, yes, on some health issues in adulthood? How do you think, Marta?
Based on research and personal experiences with that, I often think PTSD is a specific type of, again, you have to be diagnosed with PTSD. Like you had said, I think early on, most of us have gone through a traumatic, or it could be an accident, it could be displacement, it could be bullying. That's become new, where the feelings that you kind of go into, you try to escape from the bullying effects in school. Oftentimes, again, depending on if there are other protective factors protecting you and how you deal with it, it may or may not be labeled as PTSD. So you may not have PTSD, but you may have experienced adverse experiences. And that's where I think it really does indicate, even that CDC adverse childhood experiences developed from a patient with obesity. They were morbidly obese. And the more the doctor worked with the patient, it resulted in a lot of, again, because I think a trauma there's oftentimes not a beginning, middle, and end to the narrative. It's just these pieces, or something makes you start to feel anxious, but you may have put it away in the memory. So it's, I think, trying to understand what sort of childhood someone had, what they experienced. And I think it does lead to future issues, even issues, more behavioral health, or anxiety and depression, hoarding behaviors. You hear about individuals who lived through times of war or displacement, didn't have many items, and they develop in later life more of some sort of hoarding behavior, keeping things. And so I think it's important for the practitioner to understand what that person lived through, and this may be explaining their behaviors, in which case they can work with to develop a more effective treatment plan. It may not be medications, it may be different medications, it may be more behavioral therapy. So, but yes, I think there's quite a bit that...
So traumatic memory is important per se, not connected with PTSD. If there are some traumatic events, they could have poor impact on health issues, yes.
Especially, now, cardiovascular, diabetes, these may all, because I think the traumatic event, and especially if you're in a chronic stress situation, say violence in the home, or it shows, I think it's the chemical, the different, our bodies are not made to live in chronic stress, so that leads to dysfunction with different It could lead to, like I said, diabetes or poor diet or something, along those lines. So, yeah. So I think it's kind of trying to get, and oftentimes people may not remember, it could be something, but making that connection, I think, is helpful in the provider-patient relationship.
Thank you. Do you have some other questions?
I have a question.
Yeah.
Yes.
Elena?
Marta, thank you for your report. And I would like to ask you about, did you compare the effectiveness explanatory model with another therapy models? Why I ask you, because it was surprising for me that you ask patients about the reason of illness. Yeah, because traditionally we think that when we ask about reason, it impact to stuck in negative experience. It's we did not recommend psychotherapists ask this type of question.
Right. Well, it's interesting because one of the things I had written down, I forgot, the model, it's not only, it's more of a medical, it's not strictly for psychoanalysis. It's actually, it could be your family doctor asking the questions. So they're not, and I think I had put in there the trauma is not the focus of this. You're not helping the patient. I mean, you may help the patient down the line. So that's why we're asking, what do you think caused it? Because you have different, from traditional medicine, and one of the, kind of our ways of looking when patients come into care is, I'll give it one example, especially it's very popular within medical anthropology, is it happened here in one of the cities close where I live. And the whole reason, getting at the cultural context of the patient and understanding their beliefs and their methods of treatment, because they may have different healing modes. But it was a pediatrician, a mother, and I think she had migrated from, I'm not sure, one of the Southeast Asian countries, I don't remember. And one of the techniques they use is cupping to pull out the evil spirit. So she brought her child because the child wasn't getting better, but the pediatrician saw these marks on the child's body and not understanding that, so this is one of the reasons, what do you think causes the illness? And oftentimes people will say, it could be an evil spirit, it could be this. It's helpful to understand that, because the pediatrician, when he saw, this was back in I think the 1970s, 80s, when he saw the marks on the child, immediately jumped to the conclusion that it was a child abuse case, that they were, it looked like bruises on the body. And so they had to bring in and make this, do this discussion about different cultural approaches to understanding illness. And that's why you're asking, what do you think has caused your high blood pressure? And people will talk stress on the job, and it's just trying to get, they make some sort of connection, like, why do I have high blood pressure now? I didn't have it a year ago. It could be diet-related foods. There was another example of a woman with high blood pressure in the clinical setting, and within her culture, they drink pickle juice to lower to lower blood pressure. But when the medical doctor, from the biomedical perspective, all he heard was drinking pickle juice, it's high in sodium. I told you to go on a low sodium diet, But the patient's not making that connection that the pickle juice is adding to her high blood pressure. So it's almost a way to then put this on the table, discuss it, and see how you can build it into the treatment plan. So I hope that helps. Like I said, it wasn't to deal with strictly with, it's not in a psycho analysis type of situation where, again, some of the approaches may be different. This is just in a kind of the general settings to understand the mindset of the patient coming in, whether it's family practitioner, endocrinologist, psychiatrist. I mean, well, psychiatrists have their own ways, but I hope that answers a little bit.
Thank you. Thank you, Marta. And we are moving further. And the next is Kacharava Sanikidze. So Kacharava and Sanikidze. Are they present? From Georgia? No. Okay, then Andrushkina, Julia, right? Are you present?
Yes, I'm here.
Julia Andrushkina, the phenomena of foreign language anxiety. Right?
I'll try to share. I'll try to share the presentation. Is everything okay? Can you see it?
Not yet.
Not yet.
Yeah. But it's okay. We made several attempts.
Is it okay now?
Not
yet.
We cannot see, yes. We need some time.
I didn't think that it is so difficult to share the
screen. Press window. You have to plan to share the screen and then window, choose window, because you have some options, screen, window.
Screen, window. Is it possible to see my presentation now?
Unfortunately, not yet.
Unfortunately, not yet.
I think you need to open it on your desktop first to be able to share for the window.
When I... Is it better?
Yeah, probably yes.
Yes, okay. I managed to go. So, should I start?
Yeah.
Yes, okay. Language anxiety has become a great concern in foreign language learning research over the last 3 decades, and a topic that triggers significant difference of opinions. Researchers have shown that anxiety is not uncommon in almost all disciplines of learning, and the affective factors have a great influence on the process of learning. According to Cassidy, academic anxiety is a unifying formulation for the collection of anxieties learners experience while in schools. As for Spielberger, anxiety is a subjective feeling of tension, apprehension, nervousness, and very associated with the arousal of the autonomic nervous system. A large body of previous research has shown that anxiety influences language achievement. Donnay affirms that anxiety is the affective factor that affects learning the most in positive and negative way. Beneficial anxiety promotes a good performance. Krashen affirms that low anxiety appears to be conducive to second language acquisition, whether measured to personal or classroom anxiety. Debilitating level of anxiety can be traumatic for many learners, and even if they understand the message, the input will not reach the part of brain responsible for language acquisition. The explanation of this can be the affective filter hypothesis, which claims that the affective filter is a mental block caused by affective factors that prevent input from reaching the language acquisition device. Horowitz and Cope defined foreign language anxiety as a distinct complex construct of self-perception, beliefs, feelings, and behaviors related to classroom anxiety, learning arising from the uniqueness of learning process. They suggested that foreign language anxiety should be viewed as a situational, specific anxiety arising from the uniqueness of the formal language of a foreign learning of a foreign language. It is a specific syndrome that may be related to 3 main triggers associated with second language study and use. Their communication apprehension, individual discomfort in talking in front of others. Fear of negative evaluation and test anxiety. In their theory, Horvitz and Hope introduced the foreign language classroom anxiety scale as an instrument to measure anxiety levels. The foreign language classroom anxiety scale consists of 33 items with significant part correlations with the total scale aiming to access communication, apprehension, test anxiety, and fear of negative evaluation. Each item is rated in a 5-point Likert scale. Horvitz's theory have been widely accepted with subsequent research, acknowledging the uniqueness of foreign language anxiety and providing evidence that the foreign language classroom anxiety scale is a reliable tool. Also, Horvitz's theory has been widely used. Some issues have triggered rather heated debates. In terms of definitions, researchers have different opinions. Young defined it as a complicated psychological phenomenon peculiar to language learning. McIntyre and Gardner defined foreign language anxiety as the feeling of tension and apprehension, especially associated with second or foreign language contexts, including speaking, listening, and learning, or the worry and negative emotional reaction, arousal when learning or using a second or foreign language. A foreign language anxiety is based primarily on one's native language learning ability. Students' anxiety about foreign language is likely to be a consequence of their foreign language learning difficulties, and students' language learning ability is a confounding variable when studying the impact of effective differences of foreign language learning. It is the opinion of Sparks, Gameshow, and Jaworski. Opening views have been whereas much of this research into the role of anxiety in language learning has used broad-based measures. A small number of empirical studies have examined the more specific subtle effects of language anxiety. Async offered a conceptualization of anxiety in terms of cognitive interference. He suggested that anxiety arousal is associated with distracting self-related cognition, such as excessive self-evaluation, worry, over potential failure, and concern over the opinions of others. Therefore, the anxious person has her attention divided between task-related cognition and self-related cognition, making cognitive performance less efficient. This theory is able to explain the negative effects observed for language anxiety. Further, the scientists further postulated that anxious students are aware of this interference and attempt to compensate by increased effort. To diagnose state and foreign language anxiety and their possible impact on the lexical competence of a bilingual learner, we conducted a study using questionnaire based on state trait anxiety inventory introduced by Spielberger and translated by Yuri Hanin, foreign language classroom anxiety scale, and a questionnaire with a macro and micro sociological data. The main research methods were questioning and scaling. The questioning took place in full-time form using an individual questionnaire cards for about an hour. The result of the questioning was subjected to statistical analysis using descriptive statistics of both the general sample and various subsamples from it in the context of the corresponding characteristics of the respondents. The foreign language classroom anxiety scale consists of 33 statements aiming to access communication apprehension, test anxiety, and fear of negative evaluation associated with the language anxiety. 24 of the items are positively worded and 9 of the items are negatively worded. Spielberger's scale included 10 items positively worded and 10 items negatively worded. Along with the assumption of individuals' difference in the level of anxiety among students, it was necessary to make sure that they were fluent that they were fluent in a foreign language. Medvedev cites that opinion that without adequate knowledge of the vocabulary, neither linguistic competence nor linguistic usage possible. Moreover, students argue that vocabulary themselves present the greatest difficulty for them in mastering foreign language. Final grades were used as a matter of attained proficiency. Alexandra defines lexical competence as based on lexical knowledge, skills, abilities, as well as personal language and speech experience. A person's ability to differentiate the contextual meaning of a word, compare the volume and its meaning in two languages, understand the structure of the meaning of a word, and highlight the nationally specific in the meaning of a word. 155 respondents took part in the study. 47 students of Foreign Language Department of Brand State University, 57 students from non-linguistic departments, and 51 pupils of 10th and 11th grades of a secondary school. The 15-item multiple choice English achievement test was administered in the current study with a limit time of 10 minutes. The test was focused primarily on vocabulary elements. For each item, the participants circled the correct answer from two alternatives which were close in value. Then there was a translation task. 20 minutes time limit was imposed to translate 15 sentences from English into Russian. Participants were asked to write down as many associations as they could, think to their list of 15 words. Latency of the response were recorded. The number of words produced provided the score for this test. It was the third task procedure. The students were tested in the full-time form during approximately 1 hour, and the testing was conducted in small groups. First, they completed a questionnaire containing the measure of foreign language and state anxieties, then the English achievement test, translation, and association task. The respondents' answers were compared with the reference answer. The reference answer demonstrates the presence of anxiety in the answer of each question. The data obtained subjected to statistical analysis. Statistical analysis of data allowed us to find key indicators reflecting the homogeneity of the anxiety phenomena and stability of this process. The mean is the average of the data, allowing to calculate the intermediate value that is needed for statistical analysis. Variance is a measure of the spread of data around the mean. The standard deviation is a similar quantity that describes the distribution of data in sample. The difference between the minimum values shows the range of positive values. The correlation among foreign language anxiety and state anxiety scale were positive and significant, suggesting that 56 of students who experience anxiety in general are anxious performing these English language tasks. Correlation between English achievement test and anxiety were not significant, but anxious students appeared to be slightly slower to recognize that word was presented in English, but the accuracy of identification did not appear to suffer, given the time devoted to the task. It does appear that the time required to recognize the simplest item is somewhat affected by language anxiety. Translation accuracy was significantly negatively correlated with anxiety. Anxious students were not able to translate the sentences as did their relaxed counterparts. This task required students to guess the meaning of some terms, and it appears that the more anxious students did not guess as often as the more relaxed one. This may reflect anxious students' unwillingness to risk an incorrect or incomplete translation. They may avoid responding in order to avoid guessing. McIntyre and Gardner claims these effects likely arose because language anxiety interferes with both encoding and recall process. This seems to indicate that language anxiety interferes with students' ability to retrieve appropriate second language items from memory. So we can say that anxiety has a negative impact on lexical competence of a bilingual learner. So to conclude, Hastings suggested that anxiety disrupts cognitive process, but this increased effort can compensate for the effects of anxiety on quality of observed performance. The combined effect of language anxiety may be that compared with the relaxed students, anxious students have a smaller base of second language knowledge and have more difficulty demonstrating the knowledge that they do possess. So, thank you for your attention.
Thank you. Thank you, Julia. Do you have questions?
Actually,
Oh,
yeah, a quick question, and maybe I missed it. Do you know whether these students feel anxiety or suffer from anxiety in other classes, like in their native language?
Yeah, in other classes of language.
Not so much. Just they have foreign language anxiety. But is there a way to know whether they just may have other anxieties in
these students?
So saying like for here would be, I may have foreign language anxiety in Spanish, but in my regular English native language, I may not feel. Is there a way was there a way to look at that?
So if I understand your question right, so can we say that foreign language anxiety is associated only with the one language, or do the students feel the anxiety during the different classes of foreign language?
Yeah,
foreign language or just other classes.
Yeah,
just
right.
Do they suffer just generally from, say, anxiety or anxiety in other classes, and is there a way to
if we look broader at this question, we can say that students may feel academic anxiety, yes, and these negative emotions can be arise in the person, in a student, not only by foreign language, but foreign language is a unique situation when we have that triggers oral presentations and speaking around the audience, in front of the audience. Yes, test, maybe it is not the best example, but still. So when we talk about foreign languages, there are some situations which can arouse, more situations which can arouse this negative feeling. And that is why this problem is differentiated from another anxieties, and moreover, it is we conducted another experiment and we compare it: state anxiety, trait anxiety, and foreign language anxiety. And there is no, when we talk about personal anxiety, yes, trait anxiety, people who are anxious in general, they are not obligatory show their anxiety at English language classes. And just the other way around, a person who feels anxious during the classes may be very calm person in general. So their situation, their way of doing maybe during the English language, not English, foreign language classes, arouse these negative emotions in the students, and that is why these negative feelings so frequent.
Yeah, thank you. But did you associate this foreign language anxiety with social anxiety? Because general anxiety could be a bit different, like anxiety as a trait, with social anxiety, and social anxiety is connected with social situations of communication. So it's closer to this type of anxiety.
To tell the truth, I did not compare it with the social anxiety, because my aim is to see how it is reflected in the speech. And that is why it is, for me, not so important what arouse. It is it personal or social or straight? It is very important for me to see how it is reflected in the person's speech, how it impact on lexical competence, the usage of English, or I work with English, and the usage of language, foreign language, and so on and so forth. For me, it is the aim of investigation to see.
Yeah, I caught it, but we have also measure for language anxiety. It's more correct to say speech anxiety. So is it associated with speech anxiety as a speech like a mental process? Yes, or it is connected only with foreign language? Is there any specifics here?
To tell the truth, I think there is no great difference whether person speaks foreign language in his native language or maybe something else. I think that the reaction of the body, of the mind, it will be the same. We can see, if we look precise, I think that we can find a lot of examples even today for people who are feel this. We can find people who feel these negative emotions when they talk, even if their language is foreign language is very good. It is very fluent. No matter. They can feel these negative emotions. So I think that a lot of people, a very great range of people can feel these negative emotions, and this negative emotion can impact and oral speech and the listening and their writing anxiety, also mentioned when we talk about foreign language anxiety. All person's way of sharing his feeling, his thoughts, not feelings, not only feelings, but thoughts.
Thank you. Thank you very much.
Thank you for you.
Thank you.
Questions.
Okay, we are moving further. And then Olena Savchenko, psycholinguistic approach to individual information retrieval from autobiographical memory.
Okay, hi everybody. Larysa, please help me because I understand it's very difficult procedure to open the presentation.
It depends on your luck. It depends on your luck. So at the bottom of your screen there is some arrow. Did you find it? Квадратик такий з стрілочкою.
Okay, I try.
Yes, you can press it. And then you have some options: screen, window, and something else. You have to press window.
Window, then that's all.
If you're lucky, that's okay. So we are waiting.
Present now and a window, no?
Yeah, put window, but it's
no, first of all, you have to open your presentation in your computer, okay?
Yeah, you have to open your presentation. Open it.
Yeah, it's open.
Yes. It's opened, yes.
Yeah, sorry.
Yeah,
so 1 minute, maybe it's okay. I tried else. I put on share, but not the result.
Okay, but could,
1 minute.
Oh. Google Meet likes hardworking people.
Now it's starting.
Yes.
No, that's why you presented your full screen. You have to click on present now and present only a window. And the window is your presentation. You have to, I think you should...
Stop your sharing and try once more.
Okay. I
present
open
now
my presentation.
And a window.
But now, sorry. No.
Not your entire screen, just a window.
Sorry.
Yeah, we are going to do to make a little tutorial for tomorrow, because lots of people are having a hard time presenting and enlarging the PowerPoint slides.
Okay.
Yeah.
Okay.
No, yeah, without
It's the
result.
entire screen. Yeah.
It's still the screen.
No.
Or maybe you could send through email your presentation. Somebody can present it to you.
Yeah, I have presentation.
Yeah. Larysa, please help.
Okay, now I'll find it. Your presentation. Savchenko, yes, I have. Okay. Okay. Presentation, Savchenko. I'm not sure where is your presentation. No, it's not yours. Sorry. It's not yours. Try to find yours because I have too many presentations.
Okay.
No, it's THUY. But where is your presentation? Oh my gosh, where is your presentation? Try to find your presentation.
I am psycholinguistic approach.
Yeah, I see, but okay. I really cannot see it. Why? It's open, but it. Okay, probably I have to close another one. Probably too many presentations are open.
Maybe you can try to send it to me, and I can present it to you too.
Okay, I try.
On my email there.
Yeah, I see. I try, but it's maybe not very quickly. Okay. I must open the.
Maybe here. Yeah, here.
Oh, okay.
Yes. Is it okay?
And I did not see.
Could you see? Can you see?
Yeah, I see. Yeah.
Let's
Okay.
just try to press F5 or F11 to
Okay. This result is
Windows.
good. Okay, let me start. Firstly, some words about background of my research. Yeah, the psychological approach studies the text as a product of human speech activity. Future of mental process and cognitive structure reflect in the textual construction and characteristic of the story description. Ukrainian research Nataliya distinguished the following characteristic of the text as a unit of psycholinguistic analysis. Second slide, please. It's coherence, integrity, informativeness, structure, and fragmentation. Analyzing this characteristic of the text, we can predict certain psychological properties of the individual, especially features of their mental structure and cognitive process. Larysa, please, the second slide. If it's.
But can you see? Can you see presentation?
Yeah, I see.
But people, participants of our symposium, can you see?
Yes.
Yes?
Yes, yes.
Second, please.
Next, yes?
Yeah, next. Yeah.
Okay, that's not showing up.
Is that not showing up?
No.
No.
Oh,
Okay. It's
Methodology?
a methodology. It's the first, but okay.
No, we can task of
Yeah. The purpose of our study is to show the possibility of using psycholinguistic method, in particular the analysis of self-narratives, of auto-narratives, to analyze the features of autobiographical memory. In this slide, you can see the task of research, which we separated in our study. The first is introduce the autobiographical memory activation indicator, which can be determined using the method of self-narrative analysis. The second, establish the relationship of this indicator with the features of creating story about yourself. And the third is determine the relationship between this indicator and personality traits. The next, please. The main method of our research is the analysis of self-narratives. Self-narrative or autobiographical narrative is a story about oneself, a description of event of own life, own experience, in which the content of the self-concept of personality is revealed. According to my stroke, the individual objectives, the basis personal formation, attitudes, goal, motives through the creative of self-narratives. Ukrainian research Shepeleva emphasized that it is through the reproduction of self-narratives, the story of life events, and the process of realizing oneself, one life strategy. Reproduction of past event contributes the intensification of self-knowledge, self-determination, self-development of the personality. Certainly, the process of creating self-narratives depends on the organization and functioning of autobiographical memory. Sheldon, the next, please. Sheldon with colleague have identified autobiographical memory retrieval as the process of constructing mental representation of personal past episodes by associating together an array of detail related to the retrieved event. According to THUY model, autobiographical memory can be described in terms of two types of long-term memory: semantic knowledge about the self and episodic event-specific knowledge memory. In our study, we analyze the episodic type of memory, which correlate with past personal experiments. In the process of remembering and retrieval, episodic memory actively reconstructs an autobiographical experiments by associating together different experimental details, including the perceptual and conceptual elements. In the study of Rubin, it was shown that the individual difference in memory affects love story and narrative structure, stable clinic symptoms and syndromes. The confident people have in the accuracy of the autobiographical and episodic memory. The next, please. In our study, the next, please. Our study was conducted on a sample of students of the University of Ukraine. The narrative analysis of 91 individual protocols was fulfilled in order to identify the main properties of the autobiographical text, in which subject describe own behavior in a problem conflict situation, with focusing on as much details of events as possible. The 41 categories of narrative analysis were suggested. This category represents 5 generalized factors of self-narrative evaluation, namely, the first, the general characteristic of the narrative as a text. Second, the features of character description. Third, the other's position in the problem conflict situation. The next, the special aspects of the problem conflict situation. And the last, the features of storytelling. It was introduced the autobiographical memory activation indicator, which reflects the peculiarities on information retrieval. On the next slide, you can see 7 indexes which next, please. Which involve in this indicator. No, previous. Okay, yeah. Sorry, it's not very large. The degree of completeness of the social cultural context description, the degree of completeness of the text, the degree of the event description in detail, the degree of the description fullness, the average saturation of the character's description, the representation of personal qualities in the character description, and the last, the nature of others' attitude to other characters, as the assessment reflects the history of their previous interaction. In the next slide, you can see the table 1, in which I present the means of operationalization of these components. Yeah, and see on one of them, for example, the fourth, the degree of the description fullness, we can clarify through the total number of words, and you can see the scale. 0 points up to 100 words, 1 point up to 200 words, and 2 points more than 200 words as an example. I see the next slide, and in the next slide we can see the table 1. And move on the next slide. This indicator was introduced on the basis of qualitative analysis. Of course, it's need additional verification for the level of creation validity and reliability. This is the task of our next research. The next task of our study was to determine the correlation of the autobiographical memory activation indicator with the peculiarities of the self-narrative construction. To solve the problem, we use the factor analysis procedure in package statistics THANH. According to the result, is the next slide. According to the result of factor analysis of self-narrative evaluation, we can identify 11 generalized features which allow reflecting both procedure and effective characteristic of the narrative about the personal behavior in a problem conflict situation. The obtained factor structure explains more than 70% of individual differences of result, which is a high indicator of its prognostic values. You can see the resulting factor structure in the table 2. In this table, the factors was arranged from the most significant to the last one. Also, in this table, we are presenting the result of correlation analysis. Empirical indicator of each factor was calculated for each study participants. It is found that the level of autobiographical memory activation is interconnected with effective characteristic of the self-narrative. We have positive correlation with the degree of narrative completeness, disorganization in the description of traumatic situation, using the more complex form of the event description and interpretation. And also we have the procedure characteristic of storytelling. You can see positive correlation with indicator of disclosure of characters traits and the number of described events, forms of interaction between characters. These factors prove the significance of the mnemic factor in organization the text form of narration. High activity of autobiographical memory contribute to a more detailed description of participants of problem conflict situation and events, especially various forms of interaction between participants using more complex form of interpretation of these events. However, such form of activities have a negative effect on the description of traumatic events. The subjects provide a chaotic and illogical description of traumatic events, demonstrate high emotional involvement. Interesting result at the next slide. Interesting result are the correlation of the autobiographical memory activation indicator with individual parameters of the story about the problem conflict situations. Thus, correlation analysis reveals that individual with a high level of activation of autobiographical memory tells the story more coherently and consistently. In their text, reflective and regulatory plan are more represented. So they are more listening orientated. They try to maintain their interest in the story. Also, following a social structure of the story helps to establish connection between fragments of the text and to predict further events. Reflective information contains the author's understanding of the relation between facts, events, and author's attitude, the assessment of various provision in the text, awareness of their role in this situation. Okay, in my presentation, I have a lot of correlation, but I think it's maybe not very interesting. Move on the slide 15th, and the next task, yes, thank you, Larysa. The next task was to find out which personal factors determine the level of autobiographical memory activation indicator. A large set of psychodiagnostic technique was used to diagnose personal characteristic, intellectual and behavioral properties. And this slide, you can see the list of personality questionnaires and tests. On the next slide, I presented the method which studies the cognitive properties of personality. It's fourth, yeah. And the next, it's the list of methods which study behavioral strategy and practice. If you can see, we have a big set of methods, but it was surprising for us that we have only 7 significant correlation coefficients. It was crazy for me because it's a few. On the next slide, please. In this slide, you can see the significant correlation coefficients, and I try explain this result. Yeah, there are the correlation between the level of mnemic activity in of self-narrative creating and peculiarities of self-conception, presentive of negative traits, traits of yourself. The developmental level of self-regulation style, especially the ability of program of actions. The frequency of using reflective practice as activities of daily living. Self-study practice, self-testing and self-regulation, coping with anxiety practice. The level of performance-related action orientation and the frequency of using social support as a means of overcoming stress. I would like to remind you the result of research Jung, it was 1990, and colleagues, in which we showed that increasing the self-conception clarity has decreased self-continuity, but also increase the propensity to avoid autobiographical memory, which fostered self-continuity. We think that increasing the self-conception clarity can occur through the awareness of their positive and negative properties, especially negative, through the building of complex self-image. There are no connection between the indicator of mnemic activity and the formatting level of intellectual abilities, cognitive, metacognitive, and adaptive strategy. Some cognitive, reflectivity, impulsivity, the method of KHAN, and personal activity, avoiding constructive, destructive reflection styles. This result proves the relative independence of mnemic activity from the cognitive and metacognitive resource of personality. The next, please. It argues that the nature of autobiographical method, and the next, autobiographical memory is more regulative than reflective, reflective as a cognitive. These data are consistent with the result of study Wolf 1991, which shows that one of the functions of autobiographical memory is emotional regulation through mood enhancement. In conclusion, we want to emphasize that autobiographical memory can be viewed as independent factor that, in addition to cognitive and behavioral factor, determines the characteristic and process of storytelling and text as its result. In the future, we plan to conduct a comparative study of the features of autobiographical memory in the people with different level of trauma, different indicators of stress resistance. Thank you for your attention. It's all.
Thank you very much. Okay, thank you for interesting presentation. Just a moment. Yeah. Do you have any questions for Olena based on autobiographical memory and retrieval information from it?
Without question.
Okay, Elena, I have question because it's you call it also self-narrative, right?
Yeah.
I know that you study for a long period of time this topic. So I'd like to know your opinion about this classification of negative and traumatic stressful events. Is it possible to differentiate them, or it's like one type of events, but for one person it would be traumatic and for another one negative? Or what is your approach, your own approach?
Yeah, thank you for your question, Larysa. Of course, I think it's the different things because, for example, I study the problem conflict situation. I think it's negative events in our life because conflict is, of course, have negative consequences for relationship, for our mood. Yeah, but it's not traumatic, and we must understand the conflict is our background and it's normal. But I think it's very important factor is stress resistance. For some people, one event it's normal, okay, but for other people is can be traumatic. And I think we must study this in a connection. Traumatic memory and stress resistance. No, it's my point. So
okay, but could we use your indicators, as you told, coherence? You mentioned some indicators. Could we use these indicators just to differentiate, for example, different types of events in the narratives?
I think it can be, but I did not study this yet. And maybe if I compare the two type of personality with different relation to the negative events, I can separate this different. But now I can only predict, without some proofs,
Thank you. Thank you very much. I think it's possible to use these criteria, yes, to move further, more deeply in these different types of events in autobiographical narrative. Okay, some more questions? Do you have some more questions? No? Yes, okay, thank you. So let's summarize what we are talking about today. So we had 6, as for me, very interesting presentations about traumatic memory and its propositional structure, about illness narratives and controlled and uncontrolled narrative techniques, about emotional memory and communication in students with visual impairments, about illness narrative within explanatory and biopsychosocial models, about foreign language anxiety and speech anxiety in general, and autobiographical memory and retrieval information and its impact on personality. So I think there are prospects from each presentation, but if we try to summarize it, I think we present today that narrative is a very powerful psycholinguistic tool which could be used or applied to study memory representation and memory representation and the structure of memory, autobiographical, traumatic memory, yes, has an impact on well-being of people. And I mean not just memory, but this narrative as tool of expression, representation of this memory is a great, has impact on well-being of people. It could decrease physical illness, yes, and it could decrease emotional distress, for example, anxiety, language anxiety, as we were talking today, and it could enhance quality of life or well-being of people with. So probably we suggest good tool, psycholinguistic tool, yes, narrative, in order to study some mental process in our symposium is language and memory and language. Could you add something? Probably you want to add something. No? No? Okay, so thank you very much for your collaboration. I had very pleasant time. I enjoyed your presentations. Thank you. And I hope we meet next time.
Thank you
Bye-bye.
very much, Larysa and
Thank you. Maybe
others.
next time in Portugal.
Thank you.
Thank you. Thank you very much.
Larysa,
Thank
just
you.
a question. The last person didn't appear, they didn't show up?
Yes, no,
So
show up. She didn't show up.
thanks a lot. Okay, great
Thank you.
presentation.
Thank you very much. Thank you everybody for participation.
Thank you.
We'll meet tomorrow. Yes, tomorrow is the second
See you
day of
tomorrow.
our congress. Yeah, thank you. Bye
See you
bye.
tomorrow. Thank you.
Bye.
Thank
Bye-bye.
you.
Have a great day.
Bye.
Bye. Thank you.
Bye.
Bye.